Hello and welcome back to our video course on communication frameworks for clinical utility. This is video 3, more about clinical utility itself. It's the third of 4 videos. The first video is a general framework. It's about 22 minutes long. Video 2 is about 10 minutes long about clinical validity. And this one is a deeper dive into categories and outcomes for clinical utility. To recap briefly, too often we hear that your test lacks sufficient clinical utility, so you need more of it, whatever it is. But playing the right game, we'd say I understand the value proposition of your test. 30% of surgeries will be safely avoided, but I'm not convinced it will happen. I'm uncertain because of A, B, and C, and this could be addressed by certain experiments or certain data. The executive summary is that the classic phrases analytical validity, clinical utility are perfectly true. Those are 3 different aspects of using diagnostic tests, but they don't really tell people what to do or help facilitate communication during disagreements. This video will focus on categories of outcomes as shown in the lower right. The general framework shown in a diagram is that the new diagnostic test will have some gain in clinical utility, carefully described, which will have an effect on management and therapy, carefully described, which will have a gain in clinical utility, which is our goal. And we can use 6 questions to walk people through this. Who should be tested and under what circumstances? What does the test tell us that we did not know before? Can we act on the information provided by the test? In the ideal world, if everything's true, if everything's right, how well could this affect patients? Will we act on the information in the real world? What do doctors and patients actually do? Does the outcome change in a way we find value in? And can we afford it? Is it a reasonable value? And as we discussed in the first video, questions 2, 5, and 6 are comparative, so you'll ask against what comparators, in what units, and with what uncertainty. And if you don't have answers to all 3 of those features of a comparison, you haven't really made the comparison yet. We argued in the last video, video 2, that there are a finite number of ways to improve clinical validity, and we talked about that for 10 minutes. In this video, we'll talk about clinical utility. We mentioned early on that the concept of clinical utility is so basic that simply defining it is not very helpful. We'll hear that clinical utility is the incremental value in medical care, but clinical means medical care and utility means incremental value. So we've got a definition that just tells us what we already knew. We haven't pushed the ball any further down the road. I think that when people talk about defining clinical utility, they're actually talking about where are the border areas or the gray areas of the concept of clinical utility. If you have cancer and you're going to live 4 years rather than 2 years, we don't need to argue about the definition of clinical utility. But why does it often become argumentative? I would say these are 5 or 6 classic, well-accepted outcomes. More survival, unnecessary surgery avoided, a more effective drug chosen, an ineffective drug avoided, less pain, faster recovery time. No one argues if you have clear impact on those outcomes. On the other hand, on the left, we have outcomes measured only by biomarkers or imaging. And on the right, we have what people would call softer outcomes. We have a diagnosis, but we haven't yet tied it to anything else. The value of knowing, the ability to plan, perhaps a caregiver has a better grasp of prognosis. The 2 columns on the left and in the middle are physical or virtually objective. Probably less pain we can throw in as being essentially objective. The columns in the middle and on the right are perceived by the patient, patient-centered outcomes of some kind. And it's this column in the middle where you nail both aspects of these. And so that's why I think the ones in the middle are so well accepted. They're physical or objective, and they're also perceived by the patient. Now, for combination diagnostics, the clinical validity and the clinical utility tend to be redundant. So let's say we're talking about the Hercept test for giving Herceptin. The clinical validity, if you have the Hercept test and it's positive, you had an 80% chance of responding to Herceptin, which adds 6 months survival. I should have said I've made up those numbers, but you see the point. The clinical utility, if you take the test and you're positive and then you take the drug, you have an 80% chance of responding to Herceptin, which adds 6 months survival. So the clinical validity and clinical utility there are almost the same thing. And on-label combination diagnostics that pinpoint us to a drug tend to do very well with payers and other health technology assessments. I think there are gray areas to both the left and the right. For example, HIV viral load is a biomarker, but it's a very well accepted surrogate biomarker. If you have a patient with a rising HIV titer, and I can use a test to pick which drug will most dramatically affect their HIV load, that's a good test, and it helps point you to the right drug. In early breast cancer, when we do neoadjuvant therapy, if there's complete pathological response, CPR in breast cancer, that may mean you need no further chemotherapy. But complete pathological response is a laboratory test. But it means something, so it's an acceptable outcome. On the right side of the chart, I don't have time to go into this in as much detail as it might deserve, but there are a lot of fuzzy things that happen on the right side of the chart. For example, we'll do a full workup for ALS, Lou Gehrig's disease, even though there's no treatment for it. Medicare will pay for breast implants after mastectomy. There's a national coverage decision about that. But supposedly, Medicare only pays for things, prosthetics that improve the function of an organ. So what function of the organ is being restored in that case? We'll pay for cataract surgery, obviously, but would we say the ability to read or watch TV is a medical benefit? Surely people get cataract surgery a long time before they're unable to walk or unable to feed themselves. And we have things like psychotherapy for mental illness and pharmacological treatments. And of course, that's very real, but it's a subjective finding, so it would be over on the right side of the chart. There's nothing wrong with arguing about whether data is valid and then what the data means. You see this going back to the early 1600s with Galileo and William Harvey. William Harvey said, who discovered the circulation of the blood and had several means for demonstrating it. He wrote in a letter late in his life, then when he had this data about circulation of the blood, some people found it very convincing. Some people found it probably true, but some questions remained unanswered. And other people found it the same data not convincing at all. So you can go back to 1610 or 1615, and people had exactly the same arguments you'll hear in the 21st century. Pasteur and others, big debates about what things meant in the 1880s, 1890s, the dawn of modern medicine, and it's still going on today. So the point is there's nothing wrong with arguing about whether the data is valid and then what the data means, but the more clarity that argumentation has, the better. Thank you for listening to this video. If we've gotten this right, we're closer to explaining the uncertainty and explaining the disagreements when we evaluate diagnostic tests, and that should help make a decision or point the way forward to what gaps in the information needs to be addressed. If you look at something like coverage with evidence development, you shouldn't just vaguely say you need more clinical utility, so we'll cover something with coverage with evidence development, but rather there's a specific problem, like problem B, and we'll address it with a specific study, study B. There's one more video in this series which goes back to the original framework shown in video 1 and works through it step by step with several clinical examples. Thank you for listening.